Hello guys, we are starting with cardiovascular system. So the first question is, a 21-year-old man comes to the office due to recurrent heart palpitation that started and stopped abruptly. Further evaluation is indicative of an abnormal conduction pathway in the patient's heart that bypasses the AV node. Which of the following portion of the patient's ECG is most likely to be affected during the normal sinus rhythm? For this, we have to understand what each wave in ECG corresponds to. So let's look at the answer. The answer is B. So the P wave in the ECG corresponds to the atrial depolarization. Then the PR segment corresponds to the AV node conduction, which is nearly 0.1 second. This delay is because of the less number of gap junctions in the AV node. This allows proper filling of the ventricle during diastole. Then comes the ventricular depolarization, which is represented by QRS complex. The J point is an isoelectric point. Then comes the T wave. The T wave represents the ventricular repolarization, and sometimes a small U wave is also present, which represents the repolarization of papillary muscle. So this patient has PSVT, that is paroxysmal supraventricular tachycardia, which is due to Wolff-Parkinson-White syndrome. WPW syndrome is characterized by an accessory pathway which is known as bundle of Kent. This allows electrical impulse to bypass the AV node and cause pre-excitation of the ventricle. This pre-excitation leads to characteristic finding on the baseline ECG during sinus rhythm, including a shortened PR interval, slurred upslope of the QRS complex, which is known as the delta wave, a widened QRS complex. Many patients with an accessory conduction pathway are asymptomatic and diagnosed only when a WPW pattern is incidentally recognized on ECG. However, some patients will develop symptomatic arrhythmias. Atrioventricular reentrant tachycardia, that is AVRT, a type of PSVT, is the most common arrhythmia that occurs with WPW. ARVT results from a rapid reentrant circuit that typically travels down the AV node to the ventricle and back up the accessory pathway. These patients often experience palpitation or a feeling of racing heart, and the definitive treatment for this Wolff-Parkinson-White syndrome is ablation of this accessory bundle of Kent. Next question. A 34-year man comes to the clinic for evaluation of heart murmur. The patient has no chest pain, palpitation, dizziness, or shortness of breath at rest. He also exercises regularly without any abnormal symptoms. Cardiac auscultation is in the second right intercostal space reveals an ejection click along with a soft systolic murmur radiating to the neck. Soft systolic murmur radiating to the neck, most likely aortic origin. A normal volume and pressure tracing of the ventricle is shown in the image below. Which of the following letters corresponds to the opening of the valve most likely affected in this patient? Let's look at the answer. The answer is B. So look at this graph. This graph in the question represents the normal ventricular pressure. So at point B, the aortic valve opens, and at point C, the aortic valve closes. So the answer is B. So this young asymptomatic patient with a soft systolic ejection murmur at the right second intercostal space most likely has a bicuspid aortic valve. The graph above depicts the normal left ventricular pressure and volume curves during a cardiac cycle. Ventricular pressure and volume curve allows one to identify the phase of cardiac cycle and to determine the exact time of opening and closure of the cardiac valves. Aortic valve opening occurs when the left ventricular pressure exceeds the central aortic pressure at the end of isovolumetric contraction. Subsequently, left ventricular pressure continues to rise with forward blood flow into the aorta until the pressure in the left ventricle falls below the aortic pressure, leading to aortic valve closure. So aortic valve closes when the pressure in ventricle falls below the pressure in aorta and opens when the pressure in ventricle exceeds the pressure in aorta. Next question. A 10-year-old boy is brought to the emergency department due to shortness of breath and palpitation for the past day. He also has associated fever and fatigue. Vital signs indicate tachypnea, tachycardia, and hypotension. On cardiac auscultation, the patient has a new hollow systolic murmur. He is admitted to the hospital for further workup and management. A cardiac biopsy is performed due to decompensation and an unclear diagnosis. Light microscopy of the tissue specimen is shown in the image below. Which of the following most likely preceded development of the patient condition? So, in this question, the hint is fever, hypotension, and a new holosystolic murmur and the histology. So the answer for this question is bacterial infection. This histology is typical for acute rheumatic fever, which shows Ashkoff giant cells and anti-Shaw cells with caterpillar chromatin. So let's see, in acute rheumatic fever, it is an immune-mediated complication of an untreated group A streptococcal pharyngeal infection. The most serious manifestation of acute rheumatic fever is pancarditis, which can cause non-specific fever, fatigue and anorexia, as well as altered vital signs like tachycardia, tachypnea and hypotension. Endocardial involvement resulting in valvular dysfunction, especially acute mitral valve regurgitation, is the most likely cause of the patient's new holosystolic murmur. This patient's myocardial biopsy shows a lesion consisting of lymphocyte and macrophages, as well as scattered multinucleated giant cells. This interstitial myocardial granuloma or Ashkoff body is pathognomic of acute rheumatic fever related myocarditis. Plump macrophages with abundant cytoplasm and central slender chromatin ribbons called the Anichkov cells or the caterpillar cells are also often present. Over subsequent years, Ashkoff bodies are replaced by fibrous scar tissue, leading to chronic mitral valve stenosis and regurgitation. The criteria for diagnosing acute rheumatic fever is known as the Jones criteria, in which the major criteria includes joint pain, that is migratory polyarthritis, pancarditis or even endocarditis, epicarditis or pericarditis, subcutaneous nodules in the skin, erythema marginatum, which are the peripheral redness with central clearing, and Sydenham chorea, which are involuntary irregular movement of the limbs and face. For the diagnosis of acute rheumatic fever, there should be ASO titer or positive culture with two major criteria or one major or two minor criteria. Next question. A 10-year-old boy is brought to the physician by his parents due to restlessness and involuntary jerking. He takes no medication and his vaccinations are up to date. His parents do not recall any injuries or illness other than a sore throat 3 months ago. On examination, the patient has rapid, irregular jerking movement involving his face, arms and legs. This patient is at greatest risk for developing which of the following condition? So options are deforming polyarteritis, early dementia, Parkinson disease, renal failure, valvular heart disease. So the answer is valvular heart disease. So this patient's restlessness and purposeless jerking movement 3 months after having a sore throat are consistent with Sydenham chorea complication of acute rheumatic fever. This Sydenham chorea is a hyperkinetic extrapyramidal movement disorder that is the most common acquired chorea of childhood. Sydenham chorea is a neurological manifestation of acute rheumatic fever that occurs 1 to 8 months after a group A beta hemolytic streptococcal infection. This is caused by delayed onset autoimmune reaction involving anti-streptococcal antibodies that crosses the base that cross reacts with the basal ganglia. Because Sydenham chorea is a manifestation of acute rheumatic fever, patients with this disorder are at risk of chronic rheumatic heart disease and valvular heart disease. Next question. A 67-year-old man is brought to the emergency department by his son after a syncopal episode. The son was helping his father clean out the garage when the father said he felt dizzy. As the son was helping him into the chair, the patient lost consciousness. He woke up spontaneously about a minute later without any disorientation or confusion. ECG demonstrates bradycardia with a regular rhythm and a narrow QRS complexes. There is complete desynchronization between P wave and QRS complex. This line indicates that there is a heart block. Which of the following location is most likely pacing this patient's ventricle? The options are bundle of His, left bundle branch, left ventricular muscle, Purkinje system or SA node. The answer is bundle of His. See, this is the normal conduction system of the heart. The impulses are generated in the SA node. Then they travel to the AV node, and then via bundle of His they travel to the right and left bundle branch, and then to through the Purkinje fibers into the ventricular muscle. The electrical impulse in the myocardial conduction system are normally initiated by SA node at the rate of 60 to 100 per minute. These impulses are then transmitted through the atria to the AV node, then onto the bundle of His, bundle branch, Purkinje fiber and ventricular myocardium. Most of the conduction system has its own intrinsic pacemaker, which is normally suppressed by more rapid SA node pacemaker, but triggers when a signal from further up the conduction system is not received. This patient's ECG shows complete dissociation of P waves and QRS complex consistent with a third degree heart block, which is complete heart block. In third degree AV block, electrical impulse coming from SA nodes are blocked before being transmitted to the ventricle. The point of blockage usually is within the AV node or bundle of His. The cells located immediately distal to the blockage, example in bundle of His, never receives the impulse from the SA node and therefore begins regenerating their own pacemaker impulse that is transmitted to the ventricle. On ECG, the SA node impulse continue to march out as P waves and the bundle of His impulse generate their own QRS complex as an escape rhythm at the intrinsic rate of bundle of His pacemaker, that is 40 to 60 per minute. Because of atria and the ventricles are not communicating, the P waves and QRS complex have no relation to one another. Next question. Membrane potential changes in an isolated cardiac muscle cells are recorded along with ion movement across the cell membrane. Which of the following ion sequence corresponds to the region 1, 2 and 3? So this is the normal action potential of the cardiac muscle cells. We have to identify the ion responsible for each phase. So the options are given below. And the answer is, first is the sodium, second is calcium and third is potassium. So look at the normal cardiac muscle depolarization phases. This recorded action potential shows the typical profile of non-pacemaker cardiac cells. So there are two types of cells in the myocardium. One is the pacemaker cells and another is the normal non-pacemaker cells. The pacemaker cells are responsible for the rhythm generation by their automaticity, and the non-pacemaker cells are responsible for contraction. So the non-pacemaker cells, which includes the following phase. Phase 0, it is the rapid depolarization phase. This phase occurs when the resting membrane potential reaches a threshold and is characterized by rapid sodium entry into the cell due to activation and opening of voltage gated sodium channel. So this is by entry of sodium into the cell. Phase 1 is the early repolarization, caused primarily by activation of transient outward potassium currents along with a rapid decline in the inward sodium current. So this is the phase 1 and it is by efflux of the potassium ion. Phase 2 is a plateau phase, which is by calcium ions. So this is a stable membrane potential due to a balance of late inward calcium current, L type of calcium channels and outward potassium current. So they balance out each other and this results in a plateau, and this is the cause of the long refractory period in the cardiac muscles so that the cardiac muscles don't fatigue. Phase 3 is the late repolarization phase, which is by efflux of the potassium ion. This is characterized by opening of additional potassium channels, that is delayed rectifier potassium channels, and continued efflux of the potassium ions from the cell. This, in conjugation with the decay of inward calcium current, is responsible for phase 3. Phase 4 is the resting phase. This is the normal resting membrane potential between -80 and -95 millivolt, and it is generated by outward potassium flow through potassium leaky channels open at rest. The sodium potassium ATPase pump allows the potassium and sodium gradient to be maintained across the membrane. Next question. A 66-year-old man comes to the hospital due to sudden onset chest pain and dyspnea. The patient has a history of asthma and GERD, but says his current symptoms feel different than what he actually experiences. An ECG is consistent with ST segment elevation myocardial infarction, and an emergent cardiac catheterization is performed. Evaluation of the right and left coronary artery reveals left dominant circulation. A stenotic region is identified in one of the coronary vessels just before the origin of the artery supplying the AV node. Which of the following arteries is most likely affected? The options are anterior interventricular artery, left circumflex artery, left diagonal artery, right coronary artery, or right marginal artery. So the answer is left circumflex artery. So let's look at the blood supply of the heart. First of all, let's understand what is the dominant circulation means. So if the dominant side is right, that means the AV node is supplied by the right posterior interventricular artery. And if the circulation is left, means the AV node is supplied by the left posterior interventricular artery. The left posterior interventricular artery arises from the left circumflex artery. On the other hand, the right posterior interventricular artery, it arises from the right coronary artery. So let's look at the blood supply. So this is the right coronary artery and this is the left coronary artery. The right coronary artery first give a branch to the conus, which is the smooth outflow tract of the ventricle. Then it gives a acute marginal artery which supplies the inferior border of the heart. Then it goes posteriorly. If the circulation is right dominant, then it goes posteriorly as the posterior descending artery and supplies the AV node. If the dominance is left dominant, then the posterior descending artery arises from the left circumflex artery. So the left coronary artery, it gives two branches. First is the left descending artery, which is the most common artery to be occluded, and it is also known as widow's artery. This supplies the anterior 2/3 of the interventricular septum and the major portion of the left ventricle. And the second branch is left circumflex artery, which goes posteriorly, and if the circulation is left dominant, it gives off the posterior descending branch which supplies the SA node, AV node and the posterior 1/3 of the interventricular septum. So in this, coronary dominance is determined by the coronary artery that supplies the blood to the posterior descending artery. The posterior descending artery originates from one of the following: right coronary artery in approximately 70 to 80% of the population, so that will be known as right dominant. Left circumflex artery in approximately 5 to 10% of the population, that is left dominant circulation. And if both the arteries are responsible, then there will be co-dominant circulation. The AV nodal artery most often arises from the dominant coronary artery. This patient has left dominant coronary circulation. Therefore, his atherosclerotic lesion is most likely in the left circumflex artery. Involvement of AV nodal artery during myocardial infarction can cause varying degree of AV block. Initially bradycardia, then first degree heart block, then it progresses to further complicated third degree heart block. Next question. A 43-year-old man comes to the office due to occasional chest discomfort over the last 6 weeks. He thinks he is most likely experiencing musculoskeletal pain, but is concerned due to family history of heart disease. The patient has no medical condition and does not use tobacco. He leads an active lifestyle and exercise every day. He undergoes treadmill exercise stress testing. Baseline blood pressure is 122/75 and pulse is 54 per minute. After 10 minutes of exercise, his blood pressure is 155/80 and pulse is 150. He has no chest pain and ECG shows no abnormality. Compared to pre-test condition, which of the following which of the following is the single most important limiting factor for the left ventricular myocardial blood supply during the test? The options are contraction force, coronary vasoconstriction, diastolic aortic pressure, duration of diastole, interventricular pressure, systolic ventricular wall stress. So the answer is duration of diastole. So the myocardial perfusion is provided by the right and left coronary arteries, as we have seen above, arising directly from the aortic root. In contrast to most other vascular beds in the body, left ventricular myocardial perfusion occurs mainly during diastole. During ventricular systole, interventricular pressure and wall stress in the left ventricle exceeds the aortic perfusion pressure, that is more than 120, preventing effective coronary perfusion. Wall tension is highest in the subendocardial region, making this area of the myocardium particularly susceptible to ischemia. Relaxation of the left ventricle during diastole decreases intraventricular pressure to about 10 mm, which is much lower than the aortic diastolic pressure, providing a driving force that allows for adequate perfusion. Increased heart rate shortens the time of ventricular relaxation, that is duration of diastole. Therefore, the time available for maximal coronary blood flow decreases and consequently become the major limiting factor for coronary blood supply to the myocardium. So, in the summary, the blood flow to the heart occurs during the diastolic period, and blood flow to any other organ in the body occurs during the systolic period. This is mainly because during systole, the myocardium pressure is more than the aortic pressure that stops the blood flow in the coronary artery, making the myocardium more susceptible to ischemia during the systolic period. Next question. A 45-year-old man is brought to the rural emergency department due to severe chest pain, sweating and nausea. The symptoms began suddenly an hour ago. He has no significant medical history. His father died at the age 50 after experiencing sudden onset chest pain. The patient smokes a pack of cigarettes daily. He does not take any medication and has no known drug allergies. Examination shows normal heart sound and breath sound. ECG shows sinus tachycardia with ST segment elevation in lead 2, 3 and AVF. Medical management for this patient's acute condition is initiated. After initial treatment, the chest pain decreases in intensity and a reperfusion complex ventricular arrhythmia emerges. The arrhythmia is asymptomatic and resolves spontaneously. Which of the following drug is most likely responsible for rapid perfusion in this patient? Options are Altiplast, Apixaban, Ergotroban, Aspirin, Heparin, Prasugrel and Rosuvastatin. So the answer is Altiplast. So this is a case of MI. So let's look at the management of MI. So this patient has a ST segment elevation, MI, and following medical treatment experienced symptomatic improvement and reperfusion related arrhythmia. This is most likely the result of fibrinolytic or thrombolytic therapy. Fibrinolytic agents like Altiplast are indicated in patients with acute STMI who cannot receive percutaneous coronary intervention in a timely manner. Administration of these agents lead to breakdown of fibrin clot and often restoration of the myocardial perfusion. Some patients develop a self-limiting reperfusion related arrhythmias, most common an accelerated idioventricular rhythm. In the fibrinolytic pathway, the tissue plasminogen activator TPA is released by the endothelium and cleaves the plasminogen to form the plasmin. Plasmin then acts to both degrade individual fibrinogen molecule and break down fibrin clot that has already formed. The breakdown of fibrin clot leads to elevated level of fibrin split products, that is D-dimer, in the blood. Pharmacological fibrinolytic agents that are used clinically include streptokinase and recombinant form of tissue plasminogen activator like Altiplast or Tenecteplast. All of these agents inherently increase bleeding risk and are contraindicated in patients with increased risk of bleeding complication like recent hemorrhagic stroke. So after the medical therapy and initial stabilization of the patient by morphine, oxygen, nitroglycerin and aspirin, we go for a definitive treatment. So for definitive management, we have to look the first medical contact time. If the first medical contact time is less than 90 minutes, then we do a percutaneous intervention, and the artery of choice for that is the radial artery. But if the hospital does not has PCI facility, then we have to make the patient shift to another place if the door in to door out time is less than 30 minutes. Then we proceed, and if the first medical contact device is less than 120 minutes, then we do the PCI, and if it is more than 120 minutes, then we give fibrinolytic. So the trick to remember is 90 plus 30 is equals to 120. So 90 minutes first medical contact, 30 minutes travel time, and 120 minutes for the next PCI available. Next question. A 78-year woman come to the emergency department due to 3-day history of intermittent but progressive substernal chest pain. Medical history includes hypertension and hyperlipidemia, but the patient has had poor adherence to her medication and outpatient follow-up. He has a 30-pack-year smoking history. On admission, ECG reveals normal sinus rhythm with a ST segment elevation and a pathological Q wave in leads 1, AVL and V2 to V5. The patient refuses percutaneous coronary intervention and is treated medically. On the 5th day of hospitalization, she experiences severe dyspnea, sweating and hypotension. Physical examination shows raised jugular venous pressure, no heart murmur or clear lungs. She rapidly loses consciousness and becomes pulseless, and the subsequent resuscitation attempt is ineffective. Which of the following most likely contributed to the patient's death? Options are blood accumulation in the pericardial space, complete rupture of the papillary muscle, rapid perfusion of the ischemic myocardium, rupture of interventricular septum, or true aneurysm of the ventricular wall. So the answer is blood accumulation in the pericardial space. So let's look at the complication of acute myocardial infarction and the durations for them. First is the papillary muscle rupture or dysfunction. This occurs within 3 to 5 days and it is characterized by severe pulmonary edema, respiratory distress, and a new early systolic murmur associated with hypotension and cardiogenic shock. Next is interventricular septum rupture. This also occurs within 3 to 5 days. It is characterized by chest pain, new holosystolic murmur, hypotension, cardiogenic shock, also associated with a step up in oxygen level from right atrium to right ventricle. Next is free wall rupture. This occurs within 5 days up to 2 weeks. This is characterized by chest pain, distant heart sound, shock, rapid progression to cardiac arrest. Left ventricle aneurysm. This can occur up to several months, and it is characterized by heart failure, angina and ventricular arrhythmias. This patient was initially admitted with chest pain and ST segment elevation in the anterolateral ECG leads, finding consistent with an ST elevation, myocardial infarction of the left ventricle. Several days later, her abrupt onset dyspnea and hypotension were most likely due to left ventricular free wall rupture, a potential mechanical complication of transmural MI. Left ventricle free wall rupture usually occurs within 5 days but can occur up to 2 weeks following MI. During this time, the infarcted myocardial wall is substantially weakened by the coagulative necrosis, leukocyte infiltration and enzymatic lysis of the myocardial connective tissue and may be unable to withstand the shear stress generated by the high pressure left ventricle. Delayed reperfusion or absent reperfusion, as in this patient, increases myocardial damage, further weakening the left ventricular wall and increasing the risk of rupture. With left ventricular rupture, blood abruptly fills the pericardial space, resulting in hemopericardium and acute cardiac tamponade with rapidly increased intrapericardial pressure. At onset, patients may experience dyspnea, diaphoresis and sometimes chest discomfort. Diastolic filling of the relatively low pressure right-sided heart chamber is abruptly restricted, causing the jugular venous distension, and blood flow through the pulmonary circulation to the left side of the heart drops precipitously. and the lung remains clear. Cardiac output profoundly decreases, resulting in hypotension and obstructive shock that rapidly leads to cardiac arrest. Next question. A 76-year-old woman is brought to the emergency department by her son due to lethargy and confusion over the last 2 days. The patient has persistent atrial fibrillation and congestive heart failure and is on multiple medication. Recently, she has had nausea and decreasing appetite. Today, she had 3 episodes of vomiting. Patient also reports vision difficulty. Temperature is 98 degree Fahrenheit and blood pressure is 133/80. Laboratory results are sodium is 140, potassium is 5.7, calcium is 9.3, creat is 1.2, glucose 85. ECG shows junction escape rhythm at the rate of 48 per minute with occasional ventricular premature beats. Increased blood level of which of the following medication is most likely responsible for her symptoms? Options are Amiodarone, aspirin, Digoxin, diltiazem, furosemide, metoprolol, spironolactone, or valsartan. The answer is Digoxin. So this patient with atrial fibrillation and congestive heart failure has signs and symptoms of digoxin toxicity. Although calcium channel blocker and beta blocker are the preferred treatment for patients with AFib with rapid ventricular response, digoxin is a common second-line treatment that is particularly useful in patients with underlying systolic cardiac dysfunction. Its major effects are it increases the vagal tone, causing slowing of the conduction through the AV node, which is the rate control effect. Then second is sodium potassium ATPase inhibition, which causes increased intracellular sodium and calcium, which increases the cardiac contractility. Digoxin has a narrow therapeutic index, making toxicity relatively common. Symptoms of digoxin intoxication are fairly non-specific and includes nausea, abdominal pain, fatigue, dizziness, confusion, blurred vision, and abnormal color perception, mainly yellow color vision. Digoxin toxicity can cause a wide range of cardiac arrhythmias, including bradycardia and junctional escape beats due to increased AV node block. Hypokalemia can precipitate toxicity by increasing digoxin binding to sodium potassium ATPase. However, elevated potassium is a sign of digoxin toxicity, as inhibition of sodium potassium ATPase pump increases extracellular potassium. Next question. A 42-year-old man comes to the emergency department due to episode of syncope. He was standing in his kitchen this morning when he felt palpitations for about 3 seconds. Next thing he remembers is waking up on the floor. The patient has had intermittent palpitation for the last few weeks, sometimes with associated lightheadedness. He has no significant medical history other than a chronic lower back pain that began following a fall from ladder 3 years ago. The patient fractured several lumbar vertebrae in that fall and required a surgical lumbar fusion. His back pain was uncontrolled and conservative measures, and he had been treated with escalating dose of methadone for the past year. He does not smoke or drink alcohol. The patient has a remote history of IV heroin abuse but has not used it for 20 years. He has no family history of early onset heart disease, blood clot, or sudden death. Blood pressure is 120/70 in supine and 125/75 in standing. Physical examination is unremarkable. Which of the following ECG finding is most likely in this patient? Options are AV block, deep Q wave, QT interval prolongation, sinus pauses, ventricular pre-excitation. The answer is QT interval prolongation. So this patient most likely has QT interval prolongation, a common adverse effect of methadone. So let's see what are the drugs causing QT prolongation. So the mnemonic is A, B, C, D, E, F plus NO. So first are antiarrhythmics, especially class 1A and 3, and arsenic. Second is antibiotic. In antibiotics, macrolide, fluoroquinolones. Third is antipsychotic, especially haloperidol and chloroquine. Chloroquine is a anti-malarial drug. Then antidepressant, especially tricyclic antidepressants. Diuretics like thiazides, because they causes potassium loss, so they increases the toxicity of digoxin also. Antiemetic like ondansetron, antifungal like fluconazole, navirs which are anti-HIV, opioids like methadone. So QT interval prolongation is the ECG manifestation of delayed ventricular repolarization which occurs due to impairment of the voltage gated potassium channels that control the delayed rectifier potassium currents. Significantly slowing the ventricular repolarization can trigger the torsade pontis, a form of polymorphic ventricular tachycardia named for a repetitive twisting of the peak pattern. Torsade pontis is a serious arrhythmia that can cause palpitation, lightheadedness, syncope, and sudden cardiac death. Many medications, including methadone, are known to inhibit the delayed rectifier potassium currents to prolong the QT interval and predispose to torsade pontis. Methadone undergoes slow and variable hepatic clearance, making consistent avoidance of toxic blood levels challenging. Therefore, use of high doses of methadone increases the risk of QT interval prolongation and torsade pontis. Next question. A 23-year-old man comes to the emergency department with sudden onset of heart palpitation that started while he was at his desk at work. The patient has no known medical problem and does not use tobacco or illicit drugs. He drinks alcohol occasionally on the weekends. Initially, blood pressure is 110/70 and pulse is 160 per minute and regular. Gentle neck massage just below the angle of the right mandible provides immediate improvement for the condition. His blood pressure is now 120/80 and pulse is 75 per minute. Which of the following mechanism is responsible for improvement of the patient's condition? Options are decreased baroreceptor firing rate, increased sympathetic output to the SA node, increased systemic vascular resistance, prolonged AV node refractory period, prolonged ventricular myocardium refractory period. So the answer is prolonged AV node refractory period. This patient's presentation with sudden onset of palpitation and rapid regular tachycardia is consistent with PSVT, which is most often due to reentrant impulse traveling circularly between the slowly and rapidly conducting segment of the AV node. Vagal maneuvers such as carotid sinus massage, Valsalva, and cold water immersion can be used to acutely terminate the PSVT. The carotid sinuses are bulges in the internal carotid artery with baroreceptor located immediately distal to the bifurcation of common carotid artery. The carotid sinus reflex has an afferent limb that arises from the baroreceptor in the sinus and travels to the vagal nucleus and medullary center via the glossopharyngeal nerve, whereas the efferent limb carries the parasympathetic impulse to the SA node and AV node via the vagus nerve. Carotid sinus massage leads to increased afferent firing from the carotid sinus, which in turn increases the vagal parasympathetic tone. This slows conduction through the AV node and prolongs the AV node refractory period, helping to terminate the reentrant tachycardia. Next question. A 54-year-old man is transferred to the hospital from his cardiologist's office due to atrial fibrillation with rapid ventricular response. His symptoms begins 24 hours earlier with palpitation, lightheadedness, and chest tightness. The patient has had similar episodes several times during the last year. Past history is notable for mitral valve repair 3 years ago for severe symptomatic mitral regurgitation. The patient undergoes direct current cardioversion due to worsening hemodynamics instability with resolution of arrhythmias and all associated symptoms. He is considered for long-term amiodarone therapy to prevent the future arrhythmic episodes. Which of the following should be tested before initiating this medication? The options are 24 hours urinary cortisol, 24-hour urinary metanephrines, oral glucose tolerance test, serum prolactin, serum testosterone, or serum TSH. So the answer is serum TSH. So what are the side effects of amiodarone? The mnemonic is please check PFT, LFT, and TFT. So amiodarone can cause photosensitivity, corneal deposit, ceruloderma, which is also known as blue man syndrome, pulmonary fibrosis, hepatotoxicity, and thyroid dysfunction. In thyroid dysfunction, it can cause both hypo or hyperthyroidism because it interferes with the iron transport. So we will check serum TSH before starting amiodarone therapy. Next question. A new antiarrhythmic medication, drug A, is tested in a series of experiments that measure the flow of iron responsible for producing an action potential in the cardiac muscle cell. Iron flow is measured before and after the drug is administered, and the results are shown in the chart below. Drug A has antiarrhythmic effect most similar to which of the following drug? So in this we can see the change in this graph. First you have to identify what are the ions responsible for this, and then what are the drugs which inhibit this particular ion. So let's see the answer. The answer is dofetilide, and this purple is the sodium, green is calcium, and this blue is potassium. So the ion flow graph after drug A administered shows a decrease in outward potassium flow from the myocyte during the phase 3 repolarization of the myocardial action potential. Class 3 antiarrhythmic drugs. Class 3 antiarrhythmic drugs are Amiodarone, sotalol and dofetilide. The mnemonic is AIDS. Amiodarone, dofetilide and sotalol predominantly blocks the potassium channels and inhibits the outward potassium current during the phase 3 of the cardiac action potential, thereby prolonging repolarization and total action potential duration. Next question. A 82-year-old man is brought to the emergency department after a syncopal episode. He has had no chest pain or dyspnea, but he has constipation of recent onset. He was hospitalized 2 weeks ago for atrial fibrillation with rapid ventricular response and was discharged home with oral medication after appropriate management. Medical history is also significant for hypertension and severe chronic obstructive pulmonary disease requiring home supplemental oxygen. Blood pressure is 105/60 and pulse is 50 per minute. Examination reveals bilaterally decreased breath sound, no wheezing, normal heart sound. ECG shows new onset second degree AV block. Which of the following drug is most likely cause of the current condition? Options are amlodipine, diltiazem, hydrochlorothiazide, lignocaine, propranolol, terazosin and valsartan. So the answer is diltiazem. The patient's constipation and new onset second degree AV block causing syncope are likely adverse effect of the therapy with a non-dihydropyridine calcium channel blocker, example diltiazem and verapamil. These drugs are frequently used to treat hypertension, angina and supraventricular arrhythmias including atrial fibrillation, as in this patient. Non-dihydropyridine calcium channel blocker exert their primary action by blocking the L type of calcium channel, thereby decreasing the phase 0 depolarization and conduction velocity in the SA node and AV node. This leads to slowing of the sinus rate and slowing of the conduction through AV node, which can cause bradycardia and varying degree of AV block. The drugs also have a negative inotropic effect and are relatively contraindicated in patients with left ventricular systolic dysfunction. Constipation, which is typically more prominent with verapamil than diltiazem, likely occur due to reduced contraction of the colonic smooth muscles. Next question. A 60-year-old man comes to the hospital with chest pain. He has had intermittent squeezing substernal pain over the last 3 days that is now sustained. The patient has no associated palpitation, lightheadedness or shortness of breath. Medical history is notable for moderate COPD with a recent admission for exacerbation. The blood pressure is 140/90 and the pulse is 93 per minute. Oxygen saturation is 98 on room air. Physical examination shows no heart murmur and lungs are clear to auscultate. ECG shows sinus rhythm with 2 mm ST segment elevation. Cardiac tropi level are elevated. Which of the following is most appropriate treatment for this patient? Options are ibutilide, metoprolol, nadolol, propranolol, sotalol. Answer is metoprolol. So this patient's clinical presentation, chest discomfort, ST segment elevation on ECG, elevated tropi level is consistent with Acute myocardial infarction. Beta blockers are used in acute myocardial infarction to reduce myocardial oxygen demand by lowering heart rate, cardiac contractility, and afterload. They have been shown to reduce short-term morbidity, minimize infarct size, and improve the long-term survival. Contraindication to beta blockers include bradycardia or heart block, hypotension, and overt heart failure. Example, pulmonary edema. But in this we have seen the chest are clear to auscultate. So pulmonary edema is ruled out. Also, non-cardioselective beta blockers like propranolol and nadolol can trigger bronchospasm in patients with underlying COPD due to beta-2 receptor blockage and should be avoided. Cardioselective beta blockers with predominant action on the beta-1 receptors like metoprolol, atenolol, bisoprolol, and nebivolol are safe in patients with stable COPD and are the beta blocker of choice in these patients. Combined beta and alpha receptor blocker like carvedilol, labetalol are also well tolerated and have been used safely in patients with COPD. Next question. A 25-year-old man with a insignificant medical history was playing soccer when he suddenly collapsed. Despite all attempts to save his life, he died. Autopsy is performed. Gross examination of heart revealed weight of 580 gram. Normally is less than 350. The cut surface of the heart is shown in the image. If the patient had a pre-participation sports screening, cardiac auscultation would have likely revealed a murmur that increases in intensity after which of the following. So you can see the ventricular wall thickening. So the options are passive leg raising, phenylephrine infusion, squatting, sudden standing, sustained hand grip. So the answer is sudden standing. So the patient's heart shows asymmetric ventricular septal hypertrophy, a finding characteristic of hypertrophic cardiomyopathy. Dynamic left ventricular outflow tract obstruction is common in HCM and creates a heart crescendo-descendo systolic ejection murmur that is best heard along the lower left sternal border. Maneuvers or condition that decreases the left ventricle preload like abrupt standing or Valsalva strain phase, dehydration, or decreased left ventricle afterload like administration of arterial vasodilator decreases the LV blood volume to worsen the LVOT obstruction and increases the intensity of the HOCM murmur. In contrast, maneuvers or condition that increases the LV preload like passive leg raising, squatting, increasing the LV afterload like infusion of arterial vasoconstrictor like the alpha-1 agonist phenylephrine, sustained hand grip increases the left ventricular blood flow volume to alleviate left ventricle outflow tract obstruction and decreases the intensity of HCM murmur. The murmur of HCM is best differentiated from that of aortic stenosis by maneuvers that affect the LV preload. Unlike HCM, the intensity of the aortic stenosis murmur correlates directly with the LV preload. Increase in the LV preload increases the pressure gradient across the aortic valve and increases the intensity of the murmur, whereas decrease in the LV preload decrease the intensity of the murmur. Changes in the afterload have the same effect on the murmur of HCM and aortic stenosis, but for different reason. In HCM, increased afterload increases LV blood volume to relieve the left ventricle outflow tract obstruction and decrease the intensity of the murmur. In aortic stenosis, increased afterload decreases the pressure gradient across the aortic valve, decreases the intensity of murmur. So in a nutshell, basically whenever the preload increases, the intensity of the HOCM murmur decreases because the cavity opens and the outflow tract obstruction relieves. On the other hand, there is no change in the aortic stenosis murmur on changing the preload. Next question. A 58-year-old man comes to the emergency department with abrupt onset severe chest pain that radiates to his back. His blood pressure is 220 by 130 mm of mercury in the left arm and 180 by 100 in the right arm. His heart rate is 100 per minute. Initial laboratory study showed normal serum trop level. ECG is negative for ST segment changes. This patient's acute condition was most likely triggered by which of the following event? So you can see blood pressure difference in both the limbs and pain radiating to the back. The options are intimal fatty streak formation, intimal tearing, medial calcification, medial inflammation, vasa vasorum obliteration. So the answer is intimal tearing. This is a case of aortic dissection. So this patient's presentation is most consistent with aortic dissection, which is characterized by severe retrosternal chest pain radiating to the mid to upper back that can move downward as the dissection progresses. It is initiated by tear in the aortic intima that typically extends for about 1 to 5 cm in the transverse or oblique direction, and the most important risk factor for aortic dissection is hypertension. Now there is a question for you guys. Vasa vasorum obliteration is seen in which disease and which stage of that disease, and what is that appearance called? Comment in the comment box below and I'll tell you the answer. And this is the list of some important topics in cardiology.